we ask ourselves is, when we increase the number of T cells in the tumor microenvironment, how do we achieve that? Do we lead to the existing T cells to proliferate, or do we increase infiltration of new cells into the tumor microenvironment? Doing TCR sequencing using immune-seq technology, we found that we lead to proliferating T cells in the tumor microenvironment. But that technology also allowed us to look and identify to new clones of T cells that were seen on week 3 after the treatment initiated, and those clones were not existing at the baseline of the treatment. What does that mean? That there has been trafficking to the tumor microenvironment secondary to the impact of the treatment of NKTR-214 and nivolumab. We looked backwards and looked at the patients who received NKTR-214 alone in the Excel trial, which is completely different patient populations who are heavily treated. We noticed the same effect, that NKTR-214 alone can lead into trafficking of new clones of T cells that were not existing before treatment in the tumor microenvironment, and after treatment they exist. That means that NKTR-214 not only lead to proliferating cells in the blood or the tumor microenvironment, but also lead to trafficking and infiltration of a new wave of T cells to the tumor microenvironment. That has implication of what we call showering the tumor microenvironment wave after wave with the new T cells, and that possibly can reshape the tumor microenvironment and repolarize it to be anti-tumor and lead to tumor killing repertoire of T cells that can lead to anti-tumor kill possibly. And that's what is the implication. That's why it's important that, because it's not only lead to increase in the number of T cells of the existing T cells, but it leads to increase the number of T cells that newly invade the tumor microenvironment. Right. So when we talked initially about the baseline demographics of patients, we've seen that some of the patients who have high LDH or liver metastasis or PD-L1 negative, we've seen responses regardless of the status of these markers. But when we look specifically and focus onto the baseline immune features, such as the PD-L1 status or the number of CD8s at baseline before a treatment. So when you look at those factors, you can see that patients who have high PD-L1 positive, or more importantly, they have more than median of the CD8 at their baseline, their response rate was 85% with disease control rate of 100%. It's very impressive. But you can always say, well, you make the rich richer and you increase the responses in patients who are likely to respond anyway to that treatment. So when you look at the patients who don't have high CD8 at their baseline, we still see that, and those below the median, you see that the response rate was 38%, and the disease control rate was 54%. That's mean really, and that's related to the feature that we just described, that if you don't have enough T cells in the tumor microenvironment, the ability of NKTR-214, and also in combination with nivolumab, to bring in new T cells to the tumor microenvironment, increase the number of T cells in the tumor microenvironment, can increase the chance of the tumor microenvironment to respond to those invading T cells and making a tumor to start shrinking and eventually killing the tumor.